Welcome to Complicating the Narrative, a podcast that takes on the challenging questions in public health by embracing complexity rather than avoiding it. I'm your host, Selma Abdallah. The United States spends more on healthcare than any other country in the world, by a significant margin. And yet, Americans have a lower life expectancy and worse health outcomes from a number of conditions compared to peer countries. And that gap has been widening. It widened through the 2010s, and it's widened further during the COVID-19 pandemic. This is not a new observation, but what makes it so difficult to sit with is that simple explanations keep falling apart on closer inspection, particularly the argument that the US just needs to have better healthcare systems. For people who can actually access the healthcare system, the system does its job reasonably well. So if the problem isn't a failure of clinical care, and reform hasn't moved the needle, what are we actually missing? And what does it mean that more and more Americans are dying from causes that, at least on paper, we know how to address? My guest today has spent years following that thread across avoidable mortality, prevention policy, and healthcare payment reform. Dr. Jose Figueroa is an associate professor of health policy and management at the Harvard T.H School of Public Health and a practicing physician at Brigham's and Women's Hospital. Today, we will work through 3 of his papers that together make a case about American health that is harder to dismiss, precisely because it was so carefully built. Jose, thank you for joining us today.
Thank you for having me.
As we were discussing this, I think when I emailed you, my goal from this episode is we usually talk about methods of a specific paper. We run deep into an issue that an author did a lot of excellent work trying to understand deeply. What I think is fascinating about your work and the work of the colleagues that collaborate with you is that you took one specific issue and you tried to understand it across different domains. I think the methods are excellent, of course, and also you've published in really good journals, but what really fascinating to me is really try to follow the thread of a certain issue. One that I think is really important to people right now as we increasingly talk about life expectancy and why the US seems to lag behind other countries. What I want to do today is go through 3 papers that you've co-authored that look into avoidable mortality in the US, what type of intervention or prevention methods the US has to improve the health of the population, and then is the healthcare system being reformed or equipped to deal with the issues that we have in terms of increasing avoidable mortality in the US? So maybe we can start with the JAMA Internal Medicine paper. And it's as someone who really loves data, I really geeked out on that paper. I thought it was great, just different levels of data and types of data that you brought together. So do you want to talk to us a bit about that paper?
Sure. So as you started already, I think in the United States, we've been trying to deal with our country lagging behind similar high-income countries when it comes to measures of population health. The big one is life expectancy. Despite spending more than any other country in the world, we are not living as long as people in some Asian countries or in Europe. And the big question is why? Why is there a disconnect with our healthcare spending, and why are we more likely to die younger? Now, there are some big issues with the measure of life expectancy. When we're trying to figure out what can we do as a country when it comes in the hands of our healthcare system or in the hands of our public health system, not all deaths are preventable. And so then the question is, can we come up with a measure to try to figure out and look at how often are people dying from things we can prevent, where things that there's an intervention that could maybe make that person live longer. Now, there's some definitions out there. And then the first paper, it was published in JAMA Internal Medicine alongside with my colleague, Dr. Irene Papanikolaou, who's a professor at Brown University, where we looked at a measure called avoidable mortality. So what is avoidable mortality? The idea is that there are certain causes of death. For example, if someone dies from appendicitis, that could have been prevented had the person been diagnosed and referred to a healthcare setting, whether it be with a primary care doctor or surgeon, and caught it early and treated it, and then the person would have survived. So there's a definition from the WHO that says that avoidable mortality are deaths that can be avoided through timely and effective public health interventions or healthcare treatment. There's 2 components of avoidable mortality. The first component is called preventable mortality. These are things that we can do in the hands of local, state, and federal public health systems that are aimed at reducing incidence of disease or injury. So car accidents can be avoided. Deaths related to firearms can arguably be avoided, or they can be avoided if we had stricter gun control, for example. And then lots of things related to prevention from vaccines, and effective vaccine campaigns can reduce the incidence of disease. So that's one big component. The second is treatable mortality. And those are deaths that can be, again, avoided with timely and effective medical treatment. So in the case of the appendicitis case, those could be prevented as well with effective, timely diagnostics, referrals, and treatment. And so you combine it all together, and we can look at how often are people in the United States dying from things that could have been avoided compared to other high-income countries. And in that study, we compared ourselves with 40 other countries around the world, including some high-income countries, middle-income countries, and even some lower-income countries as well.
I think what was really interesting also of what you did is that you didn't treat the U.S. as a monolith, given that it's a federal system, the U.S. is so big, that you use different states
Yes.
as a unit of analysis. So do you want to tell us a bit more about why was that a choice you made?
Yes, and that's so the United States is often compared to other countries, and the big question that always comes up, is it a fair comparison? So I'll give you an example. So Norway is considered to have one of the most high-performing healthcare systems in the world. Their population lives long, they do quite well on measures of prevention, and it's often cited as a country to model yourself after. But then you ask the question, how many people live in Norway? There's about 5.7 million people. There are more people living in Massachusetts than there are in the country of Norway. The U.S. it's a very big country, 340 million people. And the people living across different states are very different. And so what we did is try to compare individual U.S. states versus individual countries to try to get an assessment of, is it really a systemic issue in the United States when it comes to avoidable mortality, or are certain states bright spots and look the equivalent of a European state? And so, yes, we did that just because we thought it was an important way of looking at the data.
Yeah, so what you did, my understanding is you used data looking into avoidable mortality, as you said, stratified by preventable mortality and treatable mortality, using data from 2009 all the way to 2021.
Mhm.
And what were your core results then?
So the first thing we found out is that across all U.S. states, pre-COVID, between 2009 to 2019, and we wanted a pre-COVID picture, avoidable mortality across all U.S. states was getting worse. In the U.S., more and more people are dying from things that could have been prevented with an effective public health system or effective, timely medical treatment. On the other hand, if you look at other countries, the majority of the other countries that we looked at, OECD countries, countries in the European Union, and other countries as well, avoidable deaths were getting better. They were actually getting better over time. So we had two different stories across U.S. states relative to other high-income countries. And that, to us, it's a systemic issue in the United States. It is not just a few states that are lagging behind. It is across all 50 states and D.C. that we looked at where things are getting worse, unfortunately, pre-COVID. Then COVID hit, and what we found is avoidable deaths were actually getting worse everywhere because of COVID. So that's not unique to the United States. But I would say that the United States, even though deaths were getting worse across the entire world, it was particularly worse in U.S. states than it was in terms of the level of increase compared to other countries. So that's the big first finding. The second thing is, if you ask what contributed to the increase in avoidable deaths in the United States, from 2009 to 2019, about 70% of the increase in avoidable deaths were related to external causes of deaths. People in the United States were more likely to die from drug use, alcohol, suicide, homicide, and traffic accidents. Whereas if you looked at other countries, they saw reductions in deaths related to those causes.
I think what was interesting to me as well, like just the first finding that even within the US, all results were not equal, right? If I remember correctly, the gap in avoidable mortality until 2019 increased actually between states, right? So some
Yes.
states kept going. I think it was Mississippi. That was the top state, if I remember from the figure that you have, that
Mhm.
kept widening the gap compared to, was it Minnesota? That was interesting to me as well, that even within the US, it seems like the gap is increasing between states.
Yes, in the United States, and which we can talk in a little bit as well,
Yeah.
is that there are concerns that inequities are getting worse, that certain states are not doing as well as other states in mitigating potential causes of death that could have been prevented. And
Yeah.
Mississippi is one of those states.
So then your third observation that was really interesting to me, or related maybe to the second one, that COVID-19 death, at least in this data set, it seems like the increase in avoidable mortality was very much linked to the base level of the country's avoidable mortality. So at least from my understanding from the data, it wasn't necessarily just what they did with COVID-19. It was the base of avoidable mortality existing before the pandemic really shaped that avoidable mortality increase you saw during the COVID-19 pandemic. Am I getting that right?
Yes, so
Yeah.
there was a signal, as you're suggesting, that if you're a country or a state that was doing particularly poorly on avoidable deaths, then when COVID-19 came, you did worse than
Yeah.
someone who was at baseline performing. And I think this speaks to the what are individual states or individual countries doing to mitigate disease, to mitigate or to reduce incidence of injury or cause of death. Then certainly that could have play a role in terms of how prepared you were to deal with the pandemic when it did hit. And then the other thing to say in the US is, unlike other countries, or at least more so than other countries, vaccine hesitancy around COVID was a major issue.
Hmm.
And that certainly played a factor as well.
And then to the, I guess the, at least for me, the really important results of spending on healthcare. I think that would also led to your future paper, if I understood it
Yes.
correctly. So do you want to talk a bit about that part?
Sure. And so I'll
Yeah.
say a couple more things in terms
Yeah.
of, in the US, the other thing that was getting worse while other countries saw benefit was deaths from cardiovascular disease. So
Yes.
that's another major issue that across all 50 states, we saw increases related to issues stemming from cardiovascular disease. Respiratory diseases were also going up over time. The one bright spot in the US is deaths related to cancer. We did see some improvements across most states, that avoidable deaths from cancer were getting better. But it's not just a unique story to the US. Other countries were also similarly seeing a benefit from reducing incidence of death from cancer.
Yeah, I think the cancer story for me was really interesting because you saw that the US deaths from cancer is getting better, but it seems like treatable mortality from cancer was getting worse, and but that was offset by preventable
Yes, so I think
reductions of,
here we're
yeah.
talking about a big cause is, there's
Yeah.
certain deaths from screening, which we'll talk about in a second. We screen in the US, we put people on preventable vaccines, for example, the HPV vaccine in the US and other causes, and those could have contributed to the reductions we saw from deaths related to cancer.
Okay, so then I recommend everyone goes and looks at the figure that you show,
Yeah.
healthcare spending compared to avoidable mortality. So what did you find
Yeah,
there?
so if you ask the question in other countries, the more a country spends in their healthcare system, is there evidence that avoidable deaths are lower? And the answer is there is a signal that the more you spend in other countries, there's a relationship with lower avoidable deaths. Now, I'll say this is observational data. It's cross-sectional. We repeat it across multiple years and the signal holds. But at least, more money in the healthcare system and in the public health system, lower avoidable deaths. Ask that same question across US states. The answer is no. And that leads, the question is spending being directed at the things that are causing us to die at a much earlier age than in other countries? And that, I think, led to the other paper that you were mentioning.
So then let's talk about the second paper, which was published in the Lancet. And what you did there was compare systematic prevention indicators. I'm actually very much interested in how you ended up selecting those indicators. I find it fascinating. Compared to 4 European countries plus Canada and Australia, as well as, if I remember correctly, you're also comparing it to the OECD average. So do you want to tell us a bit about that paper?
One common narrative that we get, it's like, we die younger prematurely in the US, and one major reason is because we underinvest in prevention. Other countries have really strong primary care systems, and that is why they live much longer than we do in the United States. And so that was a question we were trying to answer. Are we really performing poorly on prevention? Now, there's many types of prevention. And just simplistically is you can think about them as two big buckets. Prevention related to the public health care system, largely in the hands of governments, either local government, state, or federal government. And that's one component. The second side is prevention efforts in the hands of the healthcare system, the healthcare delivery system. This is where we think about like physicians and primary care doctors and other specialists that might be playing a role in trying to prevent disease. And there's primary prevention, secondary prevention, and tertiary prevention in the hands of the healthcare delivery system. So that's what we were trying to sort of compare the U.S. on public health performance versus healthcare delivery, primary care performance. Now, to your point, we looked at a lot of measures. There was like over 70 plus measures comparing the U.S. versus other countries. We try to get countries that had largely a private insurance system and some public insurance system as well. So for example, England represents the public system, and then we have other countries that have private insurers like Germany as an example. And then we then looked at the 80 measures. Now we were limited in the measures. We got them from many, many different places, from WHO, OECD, European Observatory, all different sources of data that give us hopefully a reliable measure where the numerator and denominator are comparable across countries. We'll start with the healthcare delivery system. If you ask the question, how well is the U.S. comparing with other countries on measures in the hands of primary care doctors or the healthcare delivery system, we perform better than most countries, and in some cases among the best. We're better than average. And again, in some cases among the best. Vaccination rates, we're better. We vaccinate more people for influenza, for pneumonia, more than average, I would say. When it comes to screening for breast cancer, colorectal cancer, cervical cancer, we outperform most countries. We're above average. When it comes to diagnosing disease, for example, hypertension, we're better than most countries. Contingent upon diagnosis, we are more likely than other countries to put people on treatment, meaning that you are putting them and prescribing medications. And then another big way of looking at all of the efforts in the primary care side is if you add up total dollars in the US going towards prevention, in the US we spend more on average than other countries in absolute dollars, and also in terms of our proportion of total spending, we're above average than other countries. So big picture, when it comes to measures that reflect performance of a primary care system, we are not bad in the United States. We are not underperformers. And in fact, we beat out many other countries in some of these measures. So then the question is, so why are we still more likely to die? And then you look at things related to the hands of the public health system. And then this is where I think the story in the United States is clear underlying drivers of premature mortality. But before I say like where we lag behind on the public health side, I'll just say, talk about some of the risk factors we have in the US. Yeah. So in the US, our risk factors are arguably very different than other countries. First, opioid use, way higher rates of opioid use in the general population in the United States. We have more cars on roads, and the cars that are on the road, they're often much bigger in the United States. We have more trucks, SUVs, and vans on the road, which that means if there is a car accident, the risk of injury and death is much higher with bigger vehicles on the road. Guns, huge outlier in the United States. We have way more guns per 1,000 people than any other country in the world. And then the last thing I'll say is when it comes to diet, we eat more calories than almost any other country in the world, high-income country. And then if you look at the quality of the food that we eat, it is worse. Our dietary risk which if it comes to like ultra processed foods and things that are not great for your health, the quality of the diet in the United States, it's much worse as well. So then what is the public health system doing to try to prevent this? In the United States, on motor vehicle accidents or deaths from motor vehicle accidents, the US does not have national full front seat requirements, for example. Not every state requires to have a seatbelt, the one state, for example, being New Hampshire. Also, if it looks like smoking bans across the country, there's variation. Only 29 out of the 50 states, when we looked at the data, had comprehensive smoke-free laws. So that's another major issue, whereas in other countries, it's universal. The entire country has pretty comprehensive smoke-free laws when it comes to
Yeah.
smoking in restaurants.
I guess maybe with the exception of Germany, which was very surprising to
Then
me.
Germany is the only one where I think, about 40% of the population
Yeah.
is not that. And, smoking rates in Europe, for example, are often much higher than in the US. The one
Yeah.
thing about smoking I'll say is that smoking tends to be more concentrated among lower income populations in the
Yeah.
US, whereas not as concentrated, kind of spread diffusely across other populations in Europe.
Yeah.
And then the last thing I'll say on prevention related to the public health system is we don't tax sins as much as
Yeah.
other countries. So our tax rates for wine, beer, and spirits or hard liquor is much lower than other countries. And our cigarette tax is much lower than other countries as well. So big picture,
Yeah.
even though we have a strong performance within the healthcare system, it is not enough to protect us if prevention outside the healthcare system is weak. So
Yeah.
weak public health system and high burden of risk factors that contribute to early deaths. And if you recall back, why were we increasing in the number of deaths? The majority of them are related to things that we are weak on, both on a risk factor perspective and what the public health system is doing as well.
Yeah. And I think, again, as you mentioned, what was interesting to me with all of those different indicators is that if you nitpick indicator by indicator, you might find like one country that's not doing as well as the US. So it's not necessarily that like for every single indicator, especially when it comes to prevention, the US was just performing worse than every other countries. Just when you take a holistic picture, it is clear that the US is performing worse from prevention. I'm picking on Germany exactly because of that. Because honestly, I was very surprised with the smoking bans or the smoking regulations in Germany when I looked at it compared to the US. I was also very surprised, again, just nitpicking on Germany, that Germans seem to have a much higher caloric intake than I expected, but still it was much lower than the US, if I remember correctly. So yeah, just taking all together, it paints a pretty clear picture that the US does not necessarily takes a really good approach towards prevention methods. To be completely honest, it was mind-blowing to me that we still don't have universal seatbelt laws. That was, again, just like one thing that like jumps at me, as you said,
Our
especially
friends. Our friends in New Hampshire, their motto being "Live free or die."
So I think that's a really interesting study, and as I said, it was mostly descriptive, trying to understand like different methods. And I think the real value of that study is just the different indicators that you looked at.
Yeah.
I guess to me, part of the argument. And one thing I think you mentioned earlier as well, like the U.S. actually has a younger population, so we should also have a healthier population, supposedly, at least generally speaking, which is not necessarily the case compared to other countries. But it reminded me, looking at this paper, it reminded me of the earlier paper that you had when one of the conclusions you are not asserting, but giving some potential theories for why healthcare doesn't seem to have a strong negative relationship with avoidable mortalities is that I think one of them is the healthcare system. We have a sicker population, potentially, just like we have a sicker population in general. So then it just like no matter what the healthcare system does, it doesn't seem to address the issues that the US have. If I remember correctly, please correct me if I'm
So
mistaken.
the one thing I'll say, because the U.S. is generally younger, and I will say that all of the avoidable mortality rates were age sex standardized.
Yeah. Okay.
But if
Great.
you think about the risk factors that could contribute to early death so for example, if you're trying to control diabetes and you're trying to control hypertension and you're trying to mitigate the risk of having strokes and myocardial infarctions in the US, even though again, we screen it, and if you have more likely to diagnose you and more likely to put you on medications, again, on average, they lean on high performance. To your point, we were looking at Are they leaning high performance or leaning low performance? They lean high performance on those, and sometimes among the best. But if the average population in the US is still more likely to eat poorly and not adhere to diet that we think you should be adhering to, and in the food, it's like ultra processed and all this, then it does not matter what we do as much in our healthcare
Yeah.
system to try to deal with that component. And that, I think, is a big part of the story.
Yeah, agreed. And I think one number that stuck with me, it was 2021, but I think the paper said maybe 54% of food in the US is ultra processed food, if I remember correctly. Again, mind blowing,
Yeah,
but
yeah.
maybe it
No,
shouldn't
and,
be.
and I'll say about that,
Yeah,
and I didn't
yeah,
speak about it. The important thing is that many countries regulate very heavily
yeah,
what can be sold in
yeah,
groceries and in restaurants and all that stuff.
yeah,
Whereas the US, we don't have so much regulation about what goes in our food.
yeah,
There's much that can be said. One of my colleagues, Sarah Blige, she was actually a co-author on our paper. The Lancet paper was also led by Dr. Papanikolaou at Brown University. But one of my colleagues, Sarah Blige, can tell you there that we are just not as aggressive as other countries in limiting bad things from making it to our plate. And
yeah.
and that's contributing to the obesity story, the high prevalence of diabetes, and the high prevalence of cardiovascular disease in the United States.
Yeah. So before we go to the next paper, I think just one disclaimer, because I have a lot of friends who are practicing clinicians. So I'll ask you at the end, who usually doubt the story of screening as a way of prevention leading to better outcomes. But I think what you're saying from the entire story here, or this narrative, is that it is clear that when it comes to preventive methods within the healthcare system, the U.S. performs very well. Outside of the healthcare system, it doesn't perform
Yeah.
as well. And maybe those are the factors that seem to be really driving the avoidable mortality we're seeing in the US. Second argument someone can have is to say, well, maybe the healthcare system, we're spending a lot, but we're not performing as well as we should. And there are things that we can do to improve the performance of the healthcare system, to improve the health of population when we look at spending. And I
Yeah.
think that's what your third paper trying to get at.
Yes, we started the conversation that our
Yeah,
population level outcomes are not as good as other countries, yet we're
yeah,
spending a lot of money. So then the big question is, we also have to look at what's in the spending. And two big components of spending have nothing to do, in my opinion, in terms of the quality of care. So if you do high quality care, ideally you would have better outcomes. But the two biggest drivers of high healthcare spending in the United States are high prices. We spend way more on every single unit of healthcare that we do in the US relative to other countries. We pay more for hospitalizations, we pay more for primary care visits, we pay more for specialty visits, procedures, MRIs, everything costs more in the United States. Even if you look at the drugs, right? The drugs are clearly the simplest example because it's the same drug made by the same drug manufacturer in the same factory. And that when it comes into the US, we pay anywhere from 3, 5, 8x for certain drugs that other countries are paying. The second big component that is baked into the cost of healthcare in the US is that we have one of the most complex systems when it comes to administering healthcare. We have thousands of plans, providers billing multiple people. We have a web of prior authorizations that are trying to keep people out of the healthcare system. We have all these third-party vendors trying to sort of figure out how to even get people into the door of seeing a primary care doctor or seeing a specialist. There's so much money in our system being spent on administration that at the end of the day leads to people getting less health care. And I'll say in the US, one reason people think we spend a lot of money is that we overuse health care. But we do not. That's like something that should be really important. We get hospitalized less than other countries. We see
Hmm.
doctors less than most other countries in the world. On average, when it comes to the number of drugs we take, we're not an overutilizer. There's some countries that use more drugs and other countries that use much less drugs than we do on a per person basis. So it's not that we're overutilizing healthcare. And so those are, I think, big underlying issues of the spending discordance with health outcomes. The dollars going into our healthcare system are not necessarily dollars often that are leading to better care and better health. So
Yeah.
that's one thing. So then comes that paper that I did with, Karen Joint Maddox, who's at your institution, amazing person, huge fan, mentor, friend. She was the senior author on what we got. So our goal for that paper was to summarize our experience with value-based payment in the United States.
So what does value-based payment mean?
So simplistically, value-based payment or value is you're trying to get better outcomes, better health. You can think about it as your health over dollars spent. So you can think about it as there's multiple ways of increasing value. One is you can lower costs and keep your productivity the same in terms of volume and outcomes, or you can get your quality of care or outcomes better, but keeping costs the same. And so the value-based payment in the US is really trying to figure out how to contain healthcare costs while at the same time driving more health, better outcomes in the US. So for the past 20 years, Medicare has been experimenting with many value-based payment models where the accountability of performance is increasingly in the hands of the healthcare delivery system, the clinicians, the practices, the providers, the hospitals, the nursing homes, the home healthcare agencies. Many different models, over 40 models over the last 2 decades have been implemented in an effort to try to control costs while at the same time improving outcomes.
And for those who are not in the US, the Medicare system, who does it serve and how does
Yep.
that link to public system?
Yeah, so you can think of it as our national health system in the United States. So everybody, when they turn 65, the majority of people in the US, you have to have a working history, but the majority of people in the US who are citizens or residents who've paid into the system at the age of 65, get access to our national health insurance system, which
Yeah.
is the Medicare program.
Yeah.
There are other populations that qualify for Medicare, not at the age 65. You can either qualify through disability, or some certain conditions like end-stage renal disease or some debilitating conditions like Lou Gehrig's disease. Most of the people under the age 65 qualify because of a disability, and that gets you into the Medicare program.
So what happened with your paper? At least this is very new to me as someone who doesn't work in the healthcare system. And for those listening, I love the table that you have. Is I think table 1, just explaining the different types of value-based care paradigms that you looked into in the US. So you identified 4 programs, and then you went through what they were doing.
There's 4 big flavors. Now, there's many different frameworks for categorizing these payment models, but the 4 big flavors that we came from is the first one are the public reporting programs.
Yeah.
All it is you tell, for example, a hospital, or it could be primary care doctors, practices, that kind of thing. But there are programs for hospitals where you say to the hospital, these are 10 measures, and you are required to tell me how well you're doing on 10 measures. So one of the measures could be if somebody comes in with an acute myocardial infarction, the percent of the population that you put on certain medications that we think can improve health. Another ones could be, a mortality measure or a readmission measure. Tell me
Yeah.
the percent of people who get hospitalized with, again, acute myocardial infarction and the percent of them that die within 30 days of admission. So all the program is report, and then we will penalize you if you don't. The punchline there, in the US, they don't influence outcomes. That's on average, public reporting programs have not led to meaningful improvements in outcomes. So that's like the one thing in terms of our 2-year experience with it. What they have done, though, is that they've encouraged, unfortunately, influence some risk selection avoidance of high risk populations. There's, for example, in the literature for when people get percutaneous coronary interventions, PCIs, catheterizations, doctors avoided complex patients because they were worried that it would affect the numbers. The second type of program are the pay for performance programs, P for P. So this is, you can think of it as the next level about that. Not only are you required to report on certain measures, but we will penalize you if you're a poor performer. And in some cases, we will bonus you if you're a high performer.
Yeah.
And so the literature there suggests that pay for performance models, we've had multiple in the US, on average, did not work to improve health outcomes, period. Like for the
Yeah.
most part, there's very limited evidence to suggest that the measures that were being incentivized actually led to better health outcomes for individuals. And so that necessarily did not work as well. The one thing that did, though, is that on average, safety net providers, so people who take care of more socially vulnerable, medically complex populations or minoritized populations, Black and Latino people, did worse under pay for performance models. And the big reason why that is because on average, there was no real adjustment for underlying social risk. And so the providers that are taking care of a more socially vulnerable population, which we know have higher burden of social determinants of health that could contribute to poor health and not necessarily being able to adhere to medical treatment, do worse in those models of care. So that's sort of the big story there.
Yeah.
The third model is the alternative payment models, which we call the episode-based bundles. So this one, it's not just an individual unit where it's just a hospitalization or a person visit in a primary care setting, for example, is that you will be held accountable as a hospital, for example, for the initial hospitalization and a period after the hospitalization. Within 90 days is the typical bundle. There are some bundles for surgical episodes. So, for example, after a hip replacement or knee replacement, and also for medical conditions. So, if you get hospitalized for a pneumonia or a heart failure admission, there's a 90-day window where you're sort of evaluated. And there in that window, you get evaluated for how much money you spent, and then you get evaluated for certain outcomes as well. So, big picture there, the evidence suggests that there is some evidence that bundled payment models work to reduce utilization, meaning that you tend to do less with no real evidence that there was patient harm. So a little bit of reduction in the post-hospitalization utilization, often driven by less intensive skilled nursing use when people go to a rehab facility, for example. That's where the savings tended to be. And importantly, there's no concern or increased risk of harm
Yeah.
because, the less you do, you worry that maybe patients will do worse off. So that's like the big kind of punchline of that. But there wasn't a lot of savings generated
Yeah.
by these models. It was just a little bit of reduction.
Yeah.
And then the last one are the full population based episodes. The example in the United States are accountable care organizations or ACOs. Those is when a group of providers take accountability for total cost across the inpatient, outpatient, and post-acute care setting. And then there's some quality measures that they're evaluated on. The big punchline story there as well in the US, the experience has been that ACOs save a little bit of money relative to the counterfactual because they're much better at, or a little better at keeping people out of the hospital, keeping people out of nursing homes, and keeping people more likely at, living at home. And so that's there's some reductions in utilization based on ACOs. And when you look at the quality of care, there's a little bit of a mixed story. In some measures, they do better, and other measures, they don't do as bad. But it's similar to the third example I set. If you're able to reduce costs, reduce utilization with
Yeah.
no harm in quality, that's one way of improving value. So that's the big thing. And if you go back to our earlier conversation, if you're trying to improve mortality, as we said, the majority of deaths in the United States, even among young people who are suffering from all of these diseases, are related to external factors, not necessarily to things that we do in the healthcare system. And then the last thing I'll say about the value-based payment model history in the US is all of these models were trying to influence physicians, hospitals, providers to do less healthcare. They were trying
Yeah.
to reduce utilization. But as I said earlier, there was nothing to address prices or the
Yeah.
administrative complexity. And in fact, you would argue that some of these models actually worsen the
Yeah.
administrative complexity because a lot of providers have to spend a ton of money to try to measure the outcomes and trying to sort of participate. There's billions of dollars being spent in the US just to even participate in some of these value-based payment models. And so at the end of the day, we should not be surprised that the value-based payment in its current form did not yield dramatic savings in healthcare spending because the models in their current form are not set up to address underlying drivers of spending.
Especially because I think linking it to what you said earlier about the US not actually utilizing healthcare services
Exactly.
as
Yeah.
high as other countries. So that's not, at least to my mind, as someone who doesn't
Yeah, yeah,
necessarily
yeah.
work in
So
health system. Yeah,
no,
it's
that's
not.
a great point. I mean,
Yeah,
if you're a country that
yeah,
already is on average
yeah,
hospitalizing fewer people, and then
yeah.
you have a model that is trying to get even fewer
Fair
people
people.
getting hospitalized, you're already sort of on the high performing end relative to
Yeah,
other countries. And I think this speaks to the importance of comparing ourselves to our peers,
yeah,
because you can sort of benchmark areas that we're doing poorly versus areas that we're doing quite well. And
yeah,
just another point on that, if you think about the models that reduced, that there were some savings where the episode based payment models or the population based payment models, the savings really were driven by reductions in post acute care skilled
yeah,
nursing facility use. And if you ask the question, is the U.S. a overutilizer or an underutilizer on post-acute care skilled nursing facility use, I should say that is one area where we are an overutilizer. We
sure.
send more and more people to skilled nursing facilities to do rehab, and other countries don't do that as much. And that
Yeah.
is a major driver of spending, and that's why maybe these models did work as an example.
So, do you think then the current rollbacks of the CMS system are evidence based? Because we are seeing some rollbacks saying, well, clearly some of those things don't work, so we need to roll back on that. What are your thoughts given the type of work that you're doing?
I think there's a role for value-based payment models. And I think we've learned a lot from the first wave, second wave of value-based payment models. And if you look at what was being measured and what was being incentivized, I think it comes down to those were things that we could measure. And those were things that are much more easily obtainable from providers. But they are not perfect. These measures are wrought with, issues. For example, we said, they're not great at accounting for underlying social vulnerability. And I think the next wave of alternative payment models, you have to ask the question: Are you trying to improve and lower healthcare costs? If that's the case, we need to be thinking about models that simplify the people getting care and reduce administrative complexity, that kind of thing, not
Yeah,
add to it. And then the other thing is, in my opinion, I think we need value-based payment models that are not just targeting the healthcare system. As I mentioned, much of the premature mortality in the US is being driven by external causes of death. And I would want models of care that incentivize both a strong public health system, trying to reduce incidence of disease and injury, working with the healthcare delivery side. I don't think we can separate them as much as we have. And that
yeah.
hopefully would move the needle as well.
Thank you so much, Jose. I think I want to end on a few quick questions from on the ground. So you are not just someone who's doing a lot of research on healthcare systems and how do we improve health outcomes in the US, but you're also a clinician. So I was just wondering, how does your experience day to day working in the hospital, working with the healthcare system complexities that we just talked about, align or really diverge from what you find from your work?
I'm an internal medicine physician. I practice as a hospitalist at a hospital, the Brigham and Women's Hospital in Boston, where we take care of people with complex needs and get hospitalized. The first thing I'll say is that being a clinician, I think informs my research because it puts a human face to numbers. It's very easy to look at averages across countries or across states or across health systems and try to make inference about what is behind the numbers in health system one versus health system two, or state one versus state two. But then when you're yourself a clinician taking care of people, you understand that life is not that simple, that, behind every number, there's a human, and that human comes with many, many, it comes with a lot of, we all have our own baggage, whether it be, that limited financial resources, limited support at home, losing jobs, and it just reminds me that at the end of the day, when we're designing alternative payment models or we're trying to design effective public health interventions, we have to remind ourselves that we're taking care of people, and we should have that in mind and not just be thinking about abstract hypotheticals.
Thank you. I guess our last question here is, because we are called complicating the narrative, is what would be a one narrative that needs to be complicated when we're thinking about U.S. health performance? You gave us a lot to think about today, but what would be one thing that you would want to highlight?
Yeah, and I think I'll repeat a line that I said earlier. It does not matter how strong we do as a healthcare delivery system or how much money we invest in the healthcare delivery system if we have weak performance on prevention outside the healthcare system. We have to figure out how to improve the health of people by reducing risk factors that are not always in the hands of just the primary care doctors, for example. And then also we have to have a stronger public health system as well. So we need strength in both aspects of our healthcare delivery system.
As a social determinants of health researcher, that is music to my ears to say we should think really about the prevention systems as well. Jose, thank you so much for joining us today.
Yeah, thank you for having me.
This episode was edited by Catalina Melendez-Contreras with marketing and outreach by Kenkini Bahaduri. The podcast is supported by the School of Public Health and the Frick Initiative at Washington University in St. Louis. You can find Complicating the Narrative wherever you get your podcast, and you can also watch the episodes on YouTube. If you found this conversation useful, rating, sharing, or recommending the podcast is one of the best ways to help us reach more people. Thank you for listening.